Hey guys, James saying. So today's video is about a tilt table test and what it means for you if you're going to have one. Typically this test has been ordered if you're having some syncopal or pre-syncopal episodes, if you're passing out or almost passing out, and the test will determine is that happening because of something related to your heart rate or something related to your blood pressure. Now, people can pass out if their heart rate's too fast or too slow, and people can pass out if their blood pressure is too low. So what does the test mean for you? So you'll come into some part of the hospital, oftentimes the cardiology department or the cath lab. You will end up laying on a table. You'll be connected to EKG and blood pressure, and you'll be laying on the table and you'll be strapped on the table. So you'll have typically 3 straps, one above your knees, one at your hips, and then one under your armpits. So if you're a new nurse, if somebody's new to doing this, you don't want the straps above there. You don't want somebody slipping down and it can choke them. You want the straps under the arm so it catches them when they fall, typically at their knees or above their knees to keep them from buckling. And then at the hips is an additional strap that would be nice to have too. There's a weight limit to the table. The person will be laying flat and then be raised up 80 degrees and then typically watched for a period of time. So you'll have continuous EKG, blood pressure every 3 to 5 minutes. It may be frequently if the person's having symptoms. And so what happens is you get repositioned and we're trying to see is there an inappropriate response with your heart rate or your blood pressure. Okay, so you will be on a table laying flat or supine. You have an IV started, hooked up the EKG, hooked up the blood pressure, and then you're raised up 80 degrees. And typically, it's in a darkened room. The staff will interact with you minimally so as not to negatively or unduly influence the test. And you're raised up for a certain period of time. I think we would usually do 20 minutes. And we're trying to see if there's a drop in blood pressure or if there's a change in heart rate, because some people have inappropriate responses when they change position. The heart rate, typically your veins dilate in your legs, your blood pressure drops a little bit, your heart rate should increase to compensate, but it all should happen very quickly, and most people don't feel bad or funny when they change position. So we're trying to see, is there an inappropriate response to your body with a change in body position? So you may just sit there for 20 minutes and nothing happens. If you change position and pass out, well, then you've got your answer. And the physician wants to see what happens first. Does your blood pressure drop, and then there's not a change in your heart rate like there should be? Is there a change in your heart rate? What comes first will determine how you're going to be treated. Now, after 20 minutes or so, if you don't have any passing out or pre-syncopal episodes, then you may be given a medication. We always use nitroglycerin. I've seen some protocols for isoprel, a pure beta stimulator, increase the heart rate. But we would typically give nitroglycerin 1 or 2 sprays depending on what your baseline blood pressure was. So we would make your blood pressure drop with the nitroglycerin and then see if you have an appropriate change in your heart rate. When your blood pressure drops, your heart rate should increase to compensate to maintain the same cardiac output. And if you pass out, you pass out, and then we see what happened first with your heart rate or blood pressure. Then the doctor knows how to treat you. Now, people fall into this gray area where their blood pressure drops, but they're not passing out. And sometimes a physician wants to keep going to see what eventually is going to happen. So when people's blood pressure drops, they don't feel good. Typically they're nauseated. A lot of people want to stop the test, and a few times people would make us stop the test. You have the choice of stopping the test, but you may not get your answer if you stop prematurely. So we do want to keep going until you have a significant enough change that the doctor says, okay, we can stop, or that you pass out. So that's the uncomfortable. It's either going to be a very boring test because you don't pass out, or something's going to happen and then you pass out and be like, oh, test is over. Or you be in that gray zone where you don't feel good but you haven't passed out, and the staff may want to keep going with the test. So That was the unpleasant part. It could be the unpleasant part. Now for the nurse taking care of the patient, as soon as they lost consciousness, lay them flat, raise their leg, not Trendelenburg. I always get Trendelenburg, reverse Trendelenburg, not head down. You don't want to increase pressure on the carotid sinuses. I would raise their legs up and put my foot up on the tilt table test and put their legs over my leg so that you have about 250 cc's of blood in your leg, so you get it immediately. Get a blood bolus. You might open up your IV fluids all the way. And if the patient was, if it was associated with low heart rate, you may give 0.5 milligram of atropine. But you should have your orders in your protocol. So as the nurse doing the test, if you're relatively new to this, just when the patient becomes symptomatic, you're on like stat blood pressures if you're using machines, so it just cycles over and over and over, so you have a record, continuous monitoring, so you can go back and look at every second, every exact time of the EKG that you want to look at, and be prepared. You got to have a functioning IV. Okay, you cannot have your IV below, so you have to have a functioning IV. Lay them flat quick, get their legs up quick, get the IV fluid open. If you have an order for it, if they can tolerate it, if they're CHF patient, you're probably not doing those kind of patients. But back to the patient information. So that is basically what you're going to get the answer. Something like, you may be put on medicine to keep your blood pressure from dropping. If you had an inappropriate heart rate response, like you became tachycardic, just changing position, your heart rate went from 80 to like 130, you may be put on medication to keep your heart rate from going too fast. Occasionally, we would see people with a low heart rate problem. Typically didn't see that. If you're trying to diagnose that, you may be having a loop recorder put in an event, maybe you're wearing a Holter monitor or loop recorder. That's typically how we found out people need to have pacemakers put in. So people most oftentimes didn't get a pacemaker. It's either a medicine to keep your blood pressure from going too low, medicine to keep your heart rate from going too fast, or then sometimes it'd be you get the TED, the compression hose to help venous return of the heart, and people get instruction to not get dehydrated. Some people even had orders for their salt intake to be increased. So hopefully this information is helpful. On Cath Lab Lounge on Facebook, somebody was going through the test and asking what it was, so that made me think, well, if somebody in the medical profession is asking what a tilt table test is, there's probably people in the non-medical profession, well, what's a tilt table test? So hopefully this information helps. If you liked the video, hit the thumbs up. It would help my channel. And if you found the information helpful or useful, consider subscribing to the channel. And if you do, remember to turn on notifications so that you don't miss when the next video comes out. All right, guys, thanks so much. We'll see you in the next video.